Hi everybody, and welcome to our module on platelet activation. Thrombus formation is the body's way of preventing blood loss when there's damage to the endothelial lining of blood vessels, and a thrombus is formed by the body using two ingredients. The first ingredient is a plug formed by activated platelets. The second is an insoluble molecule called fibrin, which precipitates and forms a mesh, and together the fibrin and the activated platelets form a thrombus, and this prevents blood loss. In this module, we're going to focus on formation of activated platelets. This is sometimes called primary hemostasis. In another module, we'll talk about coagulation, which is sometimes called secondary hemostasis. That leads to the formation of fibrin. Platelets are small cells that are derived from megakaryocytes in the bone marrow. They're smaller than red blood cells. If you look at this blood smear on the screen, all these red circles are red blood cells. These little purple dots are the platelets. They do not contain a nucleus, and they have a short lifespan of about 8 to 10 days, a little over a week. Their production is regulated by a substance produced in the liver called thrombopoietin. It's a glycoprotein produced mostly in the liver, and it drives production of platelets from the bone marrow, much like erythropoietin drives the production of red blood cells. Platelets circulate in the bloodstream to aid in hemostasis after vascular injury. As I said before, they're one of the two main components of thrombus, the other being fibrin. They circulate as an inactive form, but they can be activated when there's endothelial injury. They can either be activated directly by the endothelium, as we'll see in the next few slides, or they can be activated by other activated platelets so that more and more are drawn in when there's an endothelial injury. And the activated platelets work together to seal off damaged blood vessels and prevent blood loss. The process of forming a platelet plug is generally divided into three steps. First, platelets must undergo adhesion to the subendothelium. Next, they must undergo aggregation, where platelets bind to one another to form a plug. And then finally, the platelets must undergo secretion, where they release stored contents in their granules. This will activate other platelets, and the net result will be recruitment of multiple platelets to form a plug and seal openings in the vascular tree. So in the next few slides, I'm going to talk about each of these steps and break them down and go through them one at a time. Before we can talk about platelet adhesion, we have to talk about a very important substance called von Willebrand factor. Von Willebrand factor is a large glycoprotein, and it's synthesized by two important cell types. First are the endothelial cells, and second are the megakaryocytes. Now, because the megakaryocytes give rise to platelets, this means that you will find von Willebrand factor in platelets stored in the alpha granules. We'll talk more about that later. The other important source for von Willebrand factor is the endothelial cells. They store von Willebrand factor in the Weibel-Palade bodies. These are very important structures inside of endothelial cells. They can release von Willebrand factor. They can also release P-selectin, which is important for inflammation. You can also find some von Willebrand factor in the plasma. Importantly, however, von Willebrand factor is released in response to vascular injury. Activated platelets can degranulate and release von Willebrand factor, and endothelial cells that are damaged can release von Willebrand factor as well, and this will lead to platelet activation. Von Willebrand factor has three important roles in hemostasis. First of all, it is a carrier protein for factor VIII of the coagulation cascade. I discussed this in more detail in the module on coagulation, but factor VIII is released from von Willebrand factor in the presence of thrombin and becomes the activated factor VIIIa. But in the bloodstream, you can find factor VIII carried bound to von Willebrand factor. The second job of von Willebrand factor in hemostasis is to bind platelets to damaged endothelium. We'll talk more about that in a minute. And then finally, it can also bind activated platelets together as part of the process of platelet aggregation. Now, there's one other topic that we need to discuss before we can get into the details of platelet activation, and that is the topic of membrane glycoproteins. Glycoproteins contain amino acids and glucose molecules, hence the name glycoproteins, and many glycoproteins are found on the surface of platelets. Their role is to interact with other structures and molecules, and they're very important for hemostasis. And two membrane glycoproteins that are particularly important for hemostasis that we'll discuss in this module are GP1b and also GP2b3a. So now that we understand von Willebrand factor and surface glycoproteins, we can go back to our three steps of platelet plug formation and talk about them in detail. So let's start by talking about platelet adhesion. When there is vascular damage, subendothelial collagen is exposed, and subendothelial collagen is capable of binding to von Willebrand factor. Once von Willebrand factor is bound to the subendothelial collagen, it can bind the GP1b receptor on platelets. So in this manner, subendothelial collagen that is exposed can bind to von Willebrand factor, which can then bind to the GP1b receptor, and as a result, you get platelets that are adherent to the subendothelial collagen, and this is the first step in formation of a platelet plug. Once platelets have undergone adhesion to the subendothelial collagen, they can then begin to stick together. This process is called platelet aggregation. And this process is mediated by the GP2B3A receptor. This is the most abundant surface receptor found on platelets. When platelets become activated, the GP2B3A receptor changes conformation and becomes capable of binding. This receptor, although it's present on inactivated platelets, will not bind when platelets are inactivated. This process is sometimes called inside-out signaling because cell activity leads to an alteration in the receptor. Usually it's the other way around. The receptor gets altered and it triggers some cell activity. In this case, it's backwards. And I've shown this in a picture at the bottom of the screen to help you remember it. Inactivated platelets do have the 2B3A receptor, but it's not capable of binding. When the platelet becomes activated, the 2B3A receptor changes conformation and it's then capable of aggregating and sticking to other platelets. Once the 2B3A receptor changes conformation and becomes active, it can bind to either fibrinogen or von Willebrand factor, and using that as a link, it can then bind to other platelets, and this results in platelet aggregation. This is easier to understand with a picture. If we have a platelet with an activated 2B3A receptor and it comes near another platelet with an activated 2B3A receptor, the platelets cannot bind directly to one another. Instead, their 2B3A receptors will use an intermediate to link together, and that intermediate is either fibrinogen from the coagulation cascade or von Willebrand factor. So in this manner, you can get multiple platelets aggregating together to form a platelet plug, and this is the basis for the drugs called 2B3A receptors, which we'll talk about in the module on antiplatelet drugs. The third part of the process of forming a platelet plug is platelet secretion of stored contents. It's important for you to understand that platelets are activated in two different ways. They can bind to subendothelial collagen, but they can also be activated if they are exposed to activated substances released from other platelets. So when one platelet is activated, it will release stored contents which can go and activate other platelets. In this manner, one platelet being activated can lead to the activation of many others. There are many different substances stored in the alpha and dense granules. I've listed the most important ones on the screen. The alpha granules, which are the most abundant granules in platelets, contain fibrinogen, which is important for the coagulation cascade. They also contain von Willebrand factor, which we talked about before, and they also contain platelet factor 4, which we'll talk about in a minute. The dense granules contain ADP, which can activate other platelets. They also contain calcium, which is necessary for the coagulation cascade, and they also contain serotonin, which we'll talk about in a minute. Platelet factor 4 is released from the alpha granules and binds to endothelial cells, and it has numerous biological effects that have been described, but its most important clinical relevance has to do with a rare adverse effect of the blood thinner heparin called heparin-induced thrombocytopenia. This is a life-threatening side effect of heparin administration. In heparin-induced thrombocytopenia, antibodies form to platelet factor 4 complexed with heparin. The antibodies bind to platelet factor 4 and heparin, and they lead to platelet activation. This can cause thrombosis. Platelets can become low from consumption, and it's a life-threatening side effect of this drug. And I talk about this in more detail in the module on anticoagulants, but for our purposes here, I just want to point out that platelet factor 4 comes from the alpha granules in platelets, and it's intended to have biological effects, although it contributes to this dangerous side effect of heparin. Serotonin, you may know, is a neurotransmitter, but it's also stored in the dense granules of platelets, and it is released on platelet activation. And this is the basis for a screening test for heparin-induced thrombocytopenia called the serotonin release assay. In this diagnostic test for HIT, you take platelets from a donor and radiolabel them with radioactive serotonin. The patient's serum, in other words, serum from the patient you are trying to test for HIT, are added to the donor platelets along with heparin. If HIT antibodies are present, this will cause excessive serotonin release from the donor platelets, and that can be detected, and this is used sometimes as a screening test for heparin-induced thrombocytopenia. You've probably heard of adenosine diphosphate. It's used to make ATP in metabolism, but it's also a powerful activator of platelets. It's stored in the dense granules, and it's released when platelets become activated. It's also released by red blood cells when they become damaged. ADP can bind to one of two G protein receptors found on platelets. One's called the P2Y1 receptor. The other is called the P2Y12 receptor. Binding of ADP to these receptors leads to a drop in cyclic AMP formation inside of platelets, and that leads to platelet activation. There's an important tie-in here with pharmacology. There is a class of antiplatelet drugs called the phosphodiesterase inhibitors. They raise the cyclic AMP level inside of platelets, and when the cyclic AMP level is high, this blocks platelets from becoming activated, and that's how these drugs work as antiplatelet agents. We'll talk about them more in the module on antiplatelet drugs. When ADP binds to the P2Y1 receptor, the platelet will release calcium. It will also change its shape. When the P2Y12 receptor is bound, the platelet will degranulate and there's an increase in the aggregation of platelets. And many drugs function as P2Y12 receptor blocking drugs. These are often called ADP receptor blockers. They all inhibit platelet activity. We'll talk about these drugs in more detail in the module on antiplatelets, but they go by names like clopidogrel, prasugrel, ticlopidine, and ticagrelor. Another very powerful activator of platelets is thromboxane A2. Thromboxane A2 receptors are found on platelets, and this is the basis for aspirin therapy. Aspirin blocks formation of thromboxane A2. Thromboxane A2 is derived from lipids in cell membranes. There is an enzyme called phospholipase A2 found in many cells in the body, and this enzyme can pull lipids from cell membranes and convert them into molecules of arachidonic acid. This occurs in endothelial cells near damaged endothelium, and as a result, arachidonic acid is released at sites of vascular injury. Arachidonic acid is also stored in platelets. Platelets can convert arachidonic acid to thromboxane A2 using an enzyme called cyclooxygenase, and then the thromboxane A2 can be released by platelets to activate more platelets. Aspirin inhibits cyclooxygenase. This leads to less thromboxane A2, and this is why aspirin is a powerful inhibitor of platelet activation. And we'll talk more about aspirin in the module on antiplatelet drugs. The final topic I'll mention in this module is a test of platelet function called the bleeding time. This is an old test that's rarely done in the modern era. The way you perform a bleeding time test is you make a small cut on a patient's arm. You then apply filter paper to the skin and remove it at regular intervals until you see that the bleeding has stopped and the filter paper is free of blood. When this happens, you record the time it took for bleeding to stop. The reason this is a test of platelet function only is because this type of superficial bleeding is highly dependent on platelets and not very dependent on the coagulation cascade. Therefore, if the bleeding time is prolonged, it implies there is some problem with platelet function. This could be a low platelet count, for example. The patient could be taking aspirin, or there could be some inherited defect of the platelet or the platelet's ability to bind. However, the bleeding time is usually not prolonged in things like hemophilia, where the problem lies entirely with the coagulation cascade. So as I said before, this is rarely done in the modern era, but it does come up on your board exams, and what you want to remember is that the bleeding time tests platelet function, and when it's prolonged, you have to look for some explanation that lies within the platelets. And that concludes our module on platelet activation.